We are going to get started now. So thank you very much for joining us today. And we are recording this webinar for others to watch afterwards, just so you're aware. We would love if you at any point have any questions to pop them in the chat. We will endeavour to answer your questions as we go along, or at the end we'll have some time for questions and answers as well. I'll just introduce myself. I'm Jennifer Neal. I'm from Melbourne, Australia, and I'm the Secretary of the Wonka Special Interest Group on Family Violence. I'd like to introduce our two speakers today. We have Nena Kopčavar Guček, who's from Slovenia. She's a medical doctor and PhD working as a family physician in the Community Health Centre of Ljubljana. As an assistant professor, she is an active member of the faculty of the Department of Family Medicine, University of Ljubljana. Frequently, she is an invited lecturer at national and international scientific meetings, author and co-author of several scientific articles, and collaborates closely with patient associations and non-governmental organisations. She is also a previous co-convener of the Wonka World Special Interest Group on Family Violence, and she is particularly interested in family relationships and was awarded her PhD in 2015. For several years, she's represented Slovenian family practitioners in the public media and is currently the Vice President of the Slovenian Association for Family Medicine. For 13 years, she's been a volunteer doctor in the practice for patients without health insurance and has been its director since March 2024. Hagit Dascal-Weichhendler from Israel is a former co-chairperson of the Family Violence Special Interest Group. She is a family physician working full-time as a clinician with a mixed population in northern Israel, and for the past 25 years, she is the chairperson of the Committee on Family Violence in Clalit Health Services Haifa and West Galilee district, which services over 740,000 patients from multiple cultural backgrounds. The committee provides training, educational materials, counselling and support to staff on hundreds of family violence cases each year. She developed and teaches a mandatory course on family violence in the Haifa Department of Family Medicine, as well as an elective course and mandatory workshops on family violence for medical students. And she's written guidelines on family violence as well. And she's developed national simulation-based educational programs on family violence. She's also co-authored a chapter on elder abuse and neglect in the book, The Role of Family Physicians in Older People Care. So these speakers have a great wealth of experience in this area, and we're very privileged to have them present to us today. So I'll just hand over to Hagit to move our slide along, because we're just going to ask you, first of all, for those who are here, if you're able to, we'd like you just to scan the QR code. Or Hagit, would it be better if we just ask people to pop it in the chat, given we've got a nice small group? What would you prefer to do?
Okay.
If you have your phone available, we can get you just to scan this QR code, and we'll get you to tell us what your role is, so who you are, and then we're going to get you to tell us where you're from. So we'll just give you a moment to do that. And if you don't have your camera available to be able to scan the QR code, you could also just pop it in the chat to let us know who you are. So we've got someone's put in other.
Okay, let's just have people such as
maybe as we go, we can just have people pop it in the chat.
Or
so
Raquel, they can open the microphone and say where they're from, either.
Well, I'll hand over to you now, Hagit. I think Nena might be speaking first. Nena.
Okay, Nena.
Good morning, everyone. It is lovely to have you as such a precious small audience, which enables us to exchange opinions more closely and in a more intense way. First of all, I would like to point out what family violence really is. It is quite a complex issue. It is not only intimate partner violence. It is like the violence is going in concentric circles within the family, from the closer family members to those who are more in distance. It also goes from generation to generation, and we, by definition, also include the past relationships, such as stalking of your past partner or something is also family violence. Today, we would like to talk about the frail victims of family violence. Besides children, it is the elder. As the population is aging, this problem is growing more and more overwhelming. Next slide, please. And the next one as well. By the definition of WHO, it is a single or repeated act or action repeating within a relationship such as family is, where you should always be safe and trusted, and it causes harm and distress. So it is an intentional, repeated act. When we talk about elderly, is from somebody who has greater strength than the victim. So the perpetrator is somebody with greater physical strength, with greater financial strength, with greater social strength. And this act is intentional and repeated. The forms of violence are different, physical one being one of the most obvious and the easiest to prove in court, but sexual, psychological, emotional, financial, material abuse, some even say religious abuse when somebody is prevented from worshiping as they would like, is less obvious but not less hurting. Next slide, please. So how about the frequency of this? It varies in different countries from 1 of 6 to 1 of 60 victims, 60 elderly, and it is in community settings present as well as in institutions. We have to take the other position as well, and we often have to interview the perpetrators as well, because they also could be in a very tight situation, and there might be background issues which provoke the violence. So it escalated during COVID pandemics. I think there is no doubt about that. So 2 or 3 every second or third staff member from elderly institutions reports that they are perpetrators. So they are aware of that, and they are reflective. Elder abuse can lead to serious health circumstances. And I'm not speaking only of physical violence, but emotional and psychological as well. As we like to say, a word is also a weapon, and it hurts. As we were saying that the elderly population is increasing, survival is getting longer. From 2015 to 2050, so in 35 years, the population will double, even more than that. So the portion of elderly will also increase, and the problem will be growing. Next slide, please. Over to you, Jenny.
We're going to ask you in the audience, what types of elder abuse and neglect do you know or have you encountered? And we'd love to hear from you any stories of abuse and neglect in the elderly population that you've actually encountered in clinical practice. You can just put it in the chat, but you're welcome to go off mute and just let us know any types that you know about. Has anyone got anything that they want to mention? No? Well, you can keep putting things in the chat as we talk. So I wonder whether I might just hand back to you, Hagit.
Okay. So if you have, while we're talking, any memories that come up to you of cases that you have had or may have had and maybe even missed, if you have questions that you would like us to answer during the webinar, please write on the chat or open your microphone, and we will try to address them during the webinar or the questions session in the end. So as was shown before in the definition, we are talking about several types of violence which may occur. The first one and most obvious one, of course, is physical abuse. It includes any type of force being applied to another person, hitting, biting, strangling, pushing, shoving. But I marked with the red arrow some things that may be more characteristic for older people, older adults. Some of them, of course, are people that are, for example, with dementia or otherwise incapacitated. It can be feeding forcefully or restraining, okay, forcing treatment, or even inappropriate use of medications such as sedatives and so on. Any family violence can include use of weapons, but any object can be also used as a weapon, okay? The weapons can be used for threatening, for injuring, and absolutely also for killing, unfortunately. And we can think of household objects which may be used as well in such cases, and not only firearms and so on. Sexual abuse is something that is not talked enough when we're talking about older adults, but we should remember that it's not rare, it's not something that doesn't occur. And it can include forcing sex, injury during sex. It can be being treating the older person as a sexual object, touching, taking pictures, okay, and exposing the person to sexual content. We have emotional abuse, okay, which is also part of the abusive and controlling behaviors spectrum that we see in all types of family violence. Emotional abuse includes also isolating, humiliating, insulting, threatening. It can be injuring pets or destroying important objects of the person, and treating as a child, which we can see with older people. We have the financial abuse, which includes exploiting economic resources of the victim. We have abandonment, neglect, which may be physical and emotional, preventing access to medical services, to medications, to food, transportation, communication, and of course to money are things that we also can see. And of course, we have also the issue of self-neglect, which we will not tackle in depth today, but it's something that as physicians, I'm sure that everybody has the experiences and is aware of this problem. So elders, unfortunately, are more vulnerable than younger people. Any minor injury or insult can have grave consequences, increase morbidity, it will take longer convalescence time, and at the end it will increase mortality. We all learned as medical students, for example, that when a patient has breaks their femur, they have a higher risk of dying at the same year. So it's the same for any type of insult that can happen. So EAN is the short for elder abuse and neglect. We have first the direct implications, which may be short or long term. It can be pain, which can be acute or chronic, and this can cause functional impairment and a lot of other things. For example, it can cause even the patient not to eat or drink or not to get up, and they will stay in bed with all the complications that we know as physicians can happen afterwards. Of course, we have the other complications which can be caused by any insult. It can be impaired sleep, either because of pain or because they are worried about what is happening or afraid. It can cause nutrition problems, hydration problems, and it can aggravate any other condition that the patient has. Okay, if they are not taking their medications, for example, then their blood pressure, their diabetes, or other things can get out of control, and they can also develop, of course, new illnesses as a consequence. And of course, we have the mental consequences as well, depression, anxiety, and all other types of mental consequences, and of course, unfortunately, premature death. So I would like to present now a case that I had. We will call her Bianca, and in 2001, she was 70 years old. She came presenting weakness and weight loss. And we had done some lab tests, and there was anemia, iron, and B12 deficiency. I must say that when she came to the clinic, she was hungry. And I even gave her food to eat in the staff room because she was saying that she was hungry. And after we had a very candid talk, and I asked her specifically what was happening, and she disclosed that she was suffering from intimate partner violence, IPV, okay, from her long time husband for many years. She gave me consent to call social services, and I called them while she was even with me in the clinic, and they intervened quickly. They separated her pension. She was able to receive her own money, which was before controlled by the husband, and they intervened with the spouse, with the agreement of Bianca. And after several years, the spouse passed away, and she was very happy. She had very good years. She was even cooking and selling food. But as we many times see, after a few years, many years, she was now 87 years old, and she came again. She did not come, sorry, her daughter came to talk to me. And she said that she was, the mother was with weight loss again. She was staying at home. She stopped going out. She stopped cooking. She looks depressed. She doesn't want to eat. So I want you to remember this case because we will be discussing it later on the workshop, okay? So the husband actually had already passed away, as I said, so we will be thinking what might be happening here right now. Jenny?
Okay, we've got another question for you. We'd like to talk to you about who is the abuser when elder abuse and neglect. Can you think who might be potentially the perpetrator of abuse when elder and abuse and neglect are occurring? I mean, you just heard it obviously in the last case that initially the husband was, but who else might be involved in abuse, in elder abuse and neglect? And again, you can either just pop it in the chat or you can go off mute and say what you think.
Yes, please.
So spouse or children, relatives or neighbor, or perhaps the daughter. Yeah, absolutely. Yeah, all of
We're
these.
talking in general, not only on this.
Not just about the case, but about in any cases. So the caretaker. Yeah, absolutely. And the caretaker could be either paid care or could be unpaid care.
Mm-hmm. Okay, so as we saw in this case, really what we know is that sometimes intimate partner violence can continue from younger age into the older age, and sometimes the partner may be the abuser. But again, all the people that you said can be the abusers as well. And sometimes it can be also a neighbor or other people that are involved with older people that maybe sometimes don't have any family members. But we should think about the other people that are around the older person. And we will come back to the case later. Now we will continue with Nena. Wait just a second. So
Thank you, Hagit. So, where is our place in this terrible stories of violence? Every encounter that we have with our patients is a window of opportunity, or to say differently, no problems, no solutions. We first have to realize, uncover the problem, see what's really happening in order to be able to diagnose and help. So this is the first critical step to find out what's happening. As Hagit said, she was talking to the lady, asking her questions, how she was feeling at home, was she ever afraid, how were things at her home, what was happening in her family. Slowly and with the atmosphere of trust, we can get the real problem. Very rarely do patients, any age, not only elderly, report violence spontaneously. So in Europe, averagely, every patient sees their GP at least 4 to 5 times a year. So each time we have a small window of opportunity. Most of the patients will speak readily if asked. If asked. So open questions about circumstances at home will make them able to speak about this. Next slide, please. There are, however, some red flags, as we say, some specific circumstances, symptoms, risk factors, as we like to say, which make us think that this person can be victim of violence.
but it's now their turn again to open and say and write.
Right.
So please, as you were participating in who the abuser is, please write to us. What do you think are some red flags that will prompt you to inquire and to look around what's happening with your patient that is an older adult?
So Jinan has said, personally, I think our primary prevention is to educate about physiological changes related to aging. Many people are unaware.
Absolutely.
And to say again, same type of violence, where the victim is young or middle age, will have lesser and less severe consequences than in the elderly. Today we are speaking of the frailest, one of the frailest groups, not to mention the children today, but the elderly, which have severe consequences, even from screaming, demeaning, humiliating, even if nobody touches them. Their health consequences can be quite severe.
Sekinat, you had your hand up a minute ago. Have you got something that you wanted to add?
Good morning, everyone. Sorry, I'm actually on the roads. I just want to quickly drop my comments. So I think the question was, what are some of the red flags that we see that can be pointers to abuse? So the first that comes to my mind is, when you have an elderly patient with marks on their body, you don't expect an elderly patient to typically have marks on their body, and you're seeing marks, or they come to the hospital, they're looking behind their shoulders before they give you a history, or you have this reluctance to talk when somebody is around. Those are some red flags that you might have that something definitely is going on. Thank you very much. Over.
Thank you.
So I heard very badly, but I heard you said marks on the body, and what did you get? What else Sekinat was saying?
Sorry, with the audio was a little bit tricky to hear, but
Sekinat, can you say again? You said marks on the body, and you said something else.
Hello?
Yes.
Hello?
Can you hear me now?
Yeah, that's a bit better. Yeah.
Yes, I said that sometimes when they come to your consulting room and they are looking over their shoulders before they give you a history, or you just want somebody to step aside, before they give you the history you want.
Yeah.
Or, you see them disheveled. You definitely would not expect an elderly person to look rough and all of that. But you have an elderly person right before you looking malnourished, yet, the person, the relative who brought the person to the hospital is giving you a history like everything is fine. Those are telltale signs that things are going wrong, that the elderly person is unable to talk about. Thank you.
Yeah, absolutely. Jinan also said behavioral changes, isolation, and depressed mood as well.
Great. So now we can continue. Nena?
Yes, thank you, Sekinat, and thank you, Jinan. Most definitely, there are some telling signs, and we are happy to have such a learned audience already. We're just brushing up our knowledge that there are several red flags that we should be cautious about. So somebody said if they're frail, they're diseased, elderly, female are physically more frail often, and they are more prone to be victims. Disability, such as lesser physical strength, or mobility issues, or even other kinds of disabilities, such as not being able to speak, not being able to feed themselves, not being able to take care of themselves. So we are speaking of complete dependence, are also making elderly more prone to, more exposed, if you will, to be exposed to violence. So what are the risk factors on the other side? We said that we will try to take both standpoints today of the victims and of the caretakers. And if you will remember, one of two or one of three caretakers self-reports about violence. They report that they are being violent towards the elderly, be it in community or in an institution. So caretaker may have too much of a burden. I don't know about other countries, but in my country, in Slovenia, currently, we are in deep deficit of caretakers. So one caretaker, say in an institution, must be taking care of 20 or even more patients. So speaking of elderly, we would like also to underpin that neglect is a very, very frequent form of violence. In this case, the caretaker may not even be able to take care of hygienic issues, if you will, if they have so many patients. So also caretakers, as any other healthcare personnel, can have current personal crises, such as divorce, unemployment, disease in the family. They can be addictive to alcohol or other psychotropic substances. They can have a hidden psychopathology, which can be provoked by this excessive burden. They may not be informed enough or skillful enough, or they may have not had the education about, say, communicating with elderly or communicating with people who have communication issues, such as being deaf or hard of speaking. So also, what has already been stressed, past family violence, somebody, let's say a caretaker, who was a victim or a perpetrator of violence in their primary family, they're more prone to exhibit this violence in their working place as well. And family conflicts, difficult patches in our lives, as we say, make the caretakers being more prone to being violent. So what are the, now we were speaking about patient factors, caretakers factors, let's think about environmental factors. This dependence, living solely with your caretaker, your only relative, who is also the perpetrator, is a very, as we like to say, locked-in situation. Physical isolation. Elderly may not be able to use communicating tools. Maybe not all are skillful enough to use cell phone or to use computer or to use tablet. So also they might be socially isolated, living in a isolated place, say rurally somewhere, where buses are hard to get. We saw in the times of COVID that there were severe barriers to accessing healthcare or non-governmental organizations because they closed down because there were no bus connections. So that is also an impossibility. They would gladly talk or report violence, but they have no one to talk to. signs of violence on patients' beds and on furniture. Now I'm speaking of house visits, really. House visits are much more telling, if I may use this expression, about violence, as if we see the patient in our, as I like to say, sterile environment of our practice. So telltale signs. Are the sheets clean? Is there something on the bedstand, somebody who has been sick for weeks, and there's nothing, absolutely nothing, not a glass of water, no pills, no glasses, nothing to read. They're in 3 floors above, living 3 floors above their perpetrators, isolated. These are all telltale signs. I'm not saying that we are detectives, but we have to be observant. So, what are the mental health changes? We are speaking of physical now. These are the red flags that we should be cautious about. Fear, especially if we see the patient with their perpetrator simultaneously. It's excellent if you can talk to the patient alone. Loss of confidence, non-compliance. Patients are not taking drugs. Maybe they don't have them. Maybe the perpetrator didn't pick them up in the pharmacy. Delayed access to care. The mother says, please, could you take me to the doctor? Oh, you were there 2 weeks ago. You don't need to go all the time. Multiple visits with no specific reason, no specific healthcare problems can also be telltale signs. They keep coming and coming and coming in the sense of ask me, ask me. They cannot tell you spontaneously, but they would like to talk about it if the problem is disclosed. They avoid answering sometimes, and they are hard of making decision. Very, very yes, no, indecisive, as we like to say in English. Depression was already mentioned today, anxiety as well, post-traumatic stress disorder, especially in cases of physical violence, sleep disturbances, even suicidal thoughts as the greatest consequence of this depression, as self-harming, if not even trials of suicide, and addictions on the side of patients as well, excessive drinking of alcohol or so. So the caretaker, as I already said, delays access to care. They're afraid the doctor would observe something in the sense of physical marks, as was already mentioned in the interactive part just now. The caretaker blames the patient. Oh, it's all her fault. I prepare everything. She doesn't want to eat. She doesn't want to go to the doctor. It's actually vice versa. And they can be verbally violent even in encounter in practice. If we see both at the same time, please be cautious to observe the nonverbal talk, nonverbal communication between them. The hands, maybe the kicking below the table. And this is how the perpetrator tries to manipulate the patient. Next slide, please. So what do we find on clinical examination? If this was observation and history, we find all kinds of injuries in different stages of healing. Very unlikely explanations, like she was walking and she fell down the stairs, where this patient has been in a wheelchair for years. Broken teeth, especially the front teeth. Forms of objects like hematoma in the oval shape, as we cause them with fingers. Very few objects can leave this trace. So be aware of the oval hematoma, especially serial, such as several fingers in a row. No explanation for different health. Oh, I scratched this. There may be burn signs on the back of your hand caused with cigarette, and you say, oh, I did this when ironing. I have never seen a red, oval, or circular burn caused by the iron. Genital infections, sexually transmitted diseases, pain and disability in general, and functional decline, the decaying of health, not due to the aging, but to the circumstances that we're discussing now. Different forms of bleeding from the mouth, from injured teeth, or gynecological. So now about neglect. We keep saying EAN, elderly abuse and neglect. Abuse is a severe form of violence, as preventing from taking drugs, as preventing from seeing the doctor. There are also malnutrition, dehydration, already mentioned poor hygiene. They come in the winter in summer clothes, almost freezing. infestations, lack of medications or non-compliance to medication. Sometimes they report that the heat is poor in their environment. They do not have enough food, as Hagit already showed us. They have uncontrolled medical conditions. Their blood pressure has gone sky high and they never come to see us. And they are often left alone, abandoned, neglect. So over to you, Hagit. It is now your turn. Hagit, we can't hear you.
Okay, sorry. So the first thing is that we need to be alert to all the red flags that we said. So we have to look at the patient, we have to look at the caretaker, maybe do a home visit and see what we can see at the home. And of course, look at the interaction between the patient and the caretaker. And it's all very, very important. So I'm going back to Bianca and I'm asking you, what are the red flags in this case? Do you see any red flags in this case? At the last, let's go just to the last visit, when she was 87 years old. Can anyone share with us what red flags do we see here? Jenny, you must tell me if anyone is writing in the chat.
Yeah, no, I'm checking that. Oh, Sekinat has their hand up. Sekinat, do you want to say?
Yes, please. The weakness, the weight loss, patient being hungry, giving consent to call social services. All of these, are part of the red signs. Being depressed. Sorry, I'm on the road. Let me just quickly mute. Thank you.
Okay.
Thank you. And Jinan has said doesn't want to eat, weight loss. Yeah, that's right.
So absolutely, I agree with you, but just one.
Hagit, you're on mute again.
I'm sorry. So we have another case here for you. John, 80 years old, 50 years old, married, and lives with his wife, which is 77 years old. They have 2 sons, but they live far away. He has Alzheimer's disease with the mini mental score of 6 out of 30. Okay? He has diabetes, and he takes supposed to take oral medications for it, as well as hypertension, which needs treatment. He has had a CVA in the past. He's bedridden, and he requires home visits. He's obviously not coming to see us in the clinic. A recent report from the nurse that works with us, she says that the blood pressure was 190/100. They did blood tests, and the hemoglobin A1C was 10.2. She found when she examined him intertrigo, weight loss, and that his BMI had decreased from 24 to 20. So what are the red flags in this case?
Yes, Sekinat?
Uncontrolled blood pressure, uncontrolled blood glucose, intertrigo, weight loss. These are some of the red flags in this patient.
Okay, thank you. So, of course, we must say that there are differential diagnoses, okay? Some weight loss can happen in patients that are with diabetes that is uncontrolled, or with patients with dementia that decrease their food intake, or even in old age. But then we need to be more to go in depth to see what we can do. So we will continue now to see the principles of care. So some of the principles we are presenting now here. The first thing that we need to consider, what is the status of the patient, okay? Whether the patient is mentally competent, what is his functional ability, and whether it might be that legally is not competent and that we might have to report on the case. This depends on the laws in each country, which we must know. We have to be patient-centered. Whenever we have a possibility to talk with the patient and to discuss it, we must ask for consent. And while we do that, we will respect the autonomy of the patient. This is very important in all cases of family violence at any age, and also with the older people, which we sometimes tend to dismiss. But no, we must remember this. We must validate their emotions, give them the information, and ask for their agreement to do things afterwards. One of the most important principles in family violence and elder abuse and neglect is to assure the safety. Whenever we see that there might be an immediate danger, we have to act immediately, okay? And sometimes it might be to send a person to the hospital just for having them being safe or doing any other intervention that might be necessary. And another important principle is to work with an interdisciplinary team. We cannot do this alone. It is not only our job, okay? The social services, the nurses, physiotherapists, and so on must be also in the team and involved. The first thing is that we need to take a history in private, okay? We must emphasize, it was also, Sakinat, you also said that it may be a person looking over their shoulder and being providing us with some indications of body language that they're not free to speak alone. So we must always make the conditions to talk alone with the patient, and then we can take a complete history. And of course, we will also take a collateral history from the caretaker, which we might also do alone and in separate. We have a tool that we can use. It's called the EASY, Elder Abuse Suspicion Index. This is a 6-question screening tool that was validated for patients 65 years and older, which have a mini-mental score of 24 or higher. Okay, in community settings, it was translated to lots of languages, and it's copyrighted. I will show you. I will show you the tool now, and then we can also send it on the chat. Can you see the EASY tool?
Yeah.
Yes, we will not be reading all of it, but we will send it definitely afterwards in the chat, and you can download it and use it. But I also want to emphasize this is a screening tool, okay? So this can be used when we want to screen. Excuse me. So whenever we have red flags that we already saw, okay, we can start with the EASY maybe, but then we will need to go into more detailed questions, okay? And we have some examples. We will also send you the handout, and this I must say here that also these questions and the red flags, we will send also the handout in the chat. Are from a previous workshop that I did with my colleague Shelley Rothschild from the special interest group. So I must give her also the credit. So we have some questions that we can ask when we are suspecting that there is neglect, okay? For example, are you pleased with your living conditions? Do you feel safe at home? Who helps you buy groceries or prepare meals? And so on. We have some questions which we can use when we are suspecting physical or sexual abuse, okay? Did anyone touch you without your consent? Did anyone hurt you? And so on. We have some questions for financial maltreatment and some questions for emotional maltreatment. So we need to have those handy and use them whenever we are seeing red flags to what is relevant. So after we take the history in private, and we do the collateral one as well, we have of course, the physical exam, which is also important to do in private whenever possible, okay? To see, to have consent whenever possible. And it must be a complete physical whenever we are suspecting something more specific. For example, as sexual abuse, we might need to have a specialist do a gynecological exam, for example, and sometimes it may have to be with forensic possibilities to collect also evidence. We will use the laboratory and imaging also to assess the general situation, the condition of the patient, of the chronic illnesses that they have. Of course, whenever they have injuries, we might do a toxic screen. Usually this is done in hospital settings, at least in my country. If we suspect any head injury or cognitive or mental deterioration, we might need to have a head imaging as well. Of course, I said before about the house call, and Nena presented some red flags which we can see in the environment. It's very important, okay? One picture is something worth more than 1,000 words, okay? If we come and we see, like, for example, now I remember I had an Alzheimer patient, and she was bedridden, and she was in her bed. The blinds, the window was broken in the room, so it was all the time dark. They couldn't open the blinds, so she was all the time in the dark room there, without air, without a bit of sunlight. And it's things that it will never occur to me to ask about it, but when I come and I see it, it hits me that how they are treating her. And then, of course, I see a million of other signs that there are there. So you might also, when you suspect already, you might do the house call together with a multidisciplinary team, with a nurse, with a social worker, and so on. So we must take into consideration the context and the prevention issue, okay? For example, what are the risk factors, cultural issues, as well as caretaker burden, which is paramount to the working with this case and what to do, as well as to prevention, caretaker education, caretaker burden acknowledgement, and helping them out. So the primary management will be to do a problem list. Okay, it's very overwhelming to treat the whole problems together, but we might do a problem list, like, for example, for John, we might do a diabetes uncontrolled, hypertension uncontrolled, weight loss, and skin condition, and so on. And then we can make a plan specific to each problem. Of course, we try to if we can do some interventions together for some of the problems, it would be easier for us. And of course, we have to document. We must take into consideration that it may be that the abuser has access to the file, to the records, if it's like access from home and they are their legal guardian. So we might consider and think how to do it exactly and get our legal advice on it locally. And of course, we must consult, refer, or report according to the law in our country. Okay, in my country, for example, there is a duty to report whenever a person is incapacitated, not only because of age. Age in many places is not a sole factor. So you need to learn what the law is and act accordingly. And the most important thing for us as family physicians is to follow up actively, okay? Follow up the injuries, follow up the physical, the mental health problems, follow up about the functional condition of the patient, if it's improving or deteriorating or staying the same, and follow up if you did a report to social services. Are they treating it? Are they doing what is needed? Not just stand and forget, okay? because if we do so, we are a little bit of participating in the neglect of these cases as well. So we will go back to Bianca, almost near the end. It turned out when I spoke with her again, this time alone, that the son has divorced and moved in to live with her. Okay, I got this at a house call that I sat with her, and I also saw that all the house was blocked with boxes of the son. Okay, that he's controlled and taken over her house. We had, since she was responding and she was apparently cognitively intact, I had a geriatrician come to do a formal assessment to see whether I have to report on this case or I have to do what Bianca wants. So it was determined that she's capable and she will make the decisions about herself. Okay, so social services were involved, but only with her consent. I could not do a report, but only with her consent. But she did not agree to take any legal action, to make a complaint, to go to complain in the police about the son. She didn't want to do that. So after a lot of discussions, she agreed to have a live-in caretaker come to live with her. And so it was like a little bit of a buffer and somebody that was taking care of her and feeding her and maybe looking a bit what the son was doing. And there was partial improvement in her situation. She stopped losing weight and she was a little bit more, she was less depressed than before. Not happy, okay? Not happy, unfortunately, until he moved out for his own reasons. But we see here that the son is a person that growed in a family where there was intimate partner violence between the parents. And it's not surprising that he would act also violently toward his mother afterwards when he was in a personal divorce crisis. So we see this multi-generational thing many times with family violence cases. And in John's case, clearly I see that John is absolutely dependent, okay? And we should involve the adult protective services. And also we should evaluate the wife. She's 77 years old. She is the caretaker. Is she healthy, strong enough, and mentally and physically capable of taking care of him? Probably not exactly. Okay, so sometimes it will be because the caretaker is not able to do it, not because they want to harm the patient, but they don't have any other tools. So I will pass on to Nena to talk about the issue of screening now, very shortly.
Thank you, Hagit. Yes, we are approaching to the end, and now that we are all considering how often elderly become victims of violence, 1 in 6 or 1 in 60, and all the possibilities in between. And now that we know that 1 of 2 or 3 caretakers reports themselves for being violent, we start to think, should we screen everybody? Should we ask every elderly that enters our practice or that we house visit about violence? I am glad to say that just a few days ago this article was published in JAMA, Journal of American Medical Association, saying that we do not have sufficient evidence to screen everyone, which is relieving. On top of all that we do and being overburdened ourselves, we are now thinking we are obliged to screen everyone. No, actually, the recommendation from WHO and from this article is, for the time being, that there is no obvious improved benefit from screening. So what should we do? We should just assess the ones in whom we see the red flags, and we discussed them already in length, theoretically, and through the cases that Hagit has presented. So it is all in early prevention. We should detect, observe, unveil, if you will, disclose the violence before it takes severe forms. So often even the caretakers may not be aware that they are being violent. We need to alleviate their care burden and prevent violence from increasing. Next slide, please. It is true that there are barriers about reporting violence on all sides. We already said that. Patients have severe second thoughts about disclosing spontaneously, just coming in and saying, my son is beating me. Within the family, there are family secrets, and there are family dynamics issues that prevent violence from being reported. And also society may be a factor. I will just mention ageism and the standpoint that the elderly are just, I will say now, not benefiting to the society, not contributing, that they're just taking advantage, that they're just receiving their pension and not repaying for it, but they had been working all their lives. I just disclosed some of societal factors now. So when we talk to the elderly people, sometimes so many issues, health issues, psychodynamic issues, disability issues come into focus. And I asked a lady who was 97 at the time, how do you see your quality of life? Is your life worth living? And this is what she answered me. And I want us all to think about this just for a second or two. It is love that keeps us going. Thank you.
Thank you so much. What a wonderful webinar. I'm going to ask for questions, but just before I do, I'm just going to pop in the chat the website for the Family Violence Special Interest Group from Wonka, so that you can access that and see our website. And you can also, if you'd like to join the special interest group, you're most welcome to do so. But does anyone have any questions for our speakers? You can either pop them in the chat.
I will just in a minute add to the chat the file, so don't go away.
Yeah, that's right. No, we're not don't go anywhere, because we're also going to put a couple of handouts in the chat as well. So stay holding on for that, because they'll be very useful for you too. But does anyone have any questions for our speakers?
Meanwhile, I would just like to say our aim was really to be, if I may say on behalf of all of us, to be hands-on and to offer some practical advices and tools, to be as short as possible. And we really appreciate the time that you took. The weather, at least in Europe, is being very hot at the time. I believe we all are burdened with our practices and other issues. So I thank you on behalf of your patients for taking time, for being with us and sharing our impressions and knowledge. Thank you all.
Thank you so much, everyone, for joining us today.
Thank you. Bye-bye.
Bye. I'm going to stop recording now.
Bye-bye.